Hello there and welcome to this tutorial on Bell's palsy and Ramsay Hunt syndrome. Disclaimer, this video is aimed at medical students for learning and revision purposes only. For medical advice, seek a qualified clinician. Every effort has been made for the information to be as accurate as possible and in line with the UKMLA specification. However, if you find any errors, please notify in the comments. Note, this video is not sponsored or accredited by the UKMLA, MSc or GMC. Hope you find the tutorials useful. Best wishes. Bell's palsy occurs due to a lower motor neuron lesion of the facial nerve causing unilateral, i.e. one-sided partial or complete weakness of the face, which is called palsy or paralysis. The cause is idiopathic, i.e. unknown, and has a rapid onset affecting both the forehead and the mouth. Why both the forehead and the mouth? Well, both are supplied by ipsilateral lower motor neurons, i.e. there is no collateral supply. This causes weakness ipsilateral to the lesion. To understand the clinical features, let's look at the function of the facial nerve, which can be remembered by the rhyme face, ear, taste, tear. Cranial nerve 7 supplies muscles of facial expression and the orbicularis oculi, which close the eyelids. It innervates the stapedius muscle, which dampens the large vibration of the stapes. The anterior two-thirds of the tongue, the lacrimal glands, and salivary glands are also supplied by the facial nerve. Hence, a lesion here will result in dry eyes, as one can no longer close them, changes in their taste and tears, and hyperacusis, as loud sounds cannot be dampened. Here is an image of a person with Bell's palsy. Note that he is unable to raise the right side of his forehead, nor smile on the right side. So where is the lesion? It is in the right lower motor neuron. Bell's palsy is a clinical diagnosis, hence there are no diagnostic tests. There are some risk factors associated with Bell's palsy, which includes upper respiratory tract infections being the commonest cause, immunosuppression, especially HIV, pregnancy, and diabetes. Note that sarcoidosis can cause bilateral Bell's palsy. Management is with high-dose prednisolone, started within 72 hours of onset. Eye lubricants are indicated to stop the eye drying and prevent exposure keratopathy, i.e. stop the cornea being damaged. And if there is no improvement after 3 weeks, urgently refer to an ENT specialist. Note that most people will recover within 4 months. A variant of Bell's palsy is Ramsay Hunt syndrome, also called herpes zoster oticus, which presents with clinical features of Bell's palsy and a painful vesicular rash, often in the ear. It occurs due to reactivation of the varicella zoster virus infecting the facial nerve. It presents with intense ear pain, tinnitus, which is a ringing sensation in the ear, hearing loss, and vertigo if the vestibulocochlear nerve is also affected. Management is with IV acyclovir to prevent post-herpetic neuralgia, which is a burning pain in the nerves, and prednisolone.